Hi, and welcome back to the WHY-O-MYO podcast. This is Janine Steen, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy. Disclaimer. All content and details, as well as education shared on the podcast, are the opinions of the speaker and for informational purposes only. Please consult with a certified medical professional regarding any questions or concerns, as this podcast should not serve as a diagnosis or replace the information that you have received from a healthcare provider. Hi, everyone. It's nice to be back. I wanted to take this opportunity to talk to you a little bit about some of the lectures I've been going to lately, all around the country, actually. And each of the lectures had a pretty strict airway focus at some point. Ironically, however, myofunctional therapy was suggested, recommended, mentioned very infrequently. Depending on the course or the conference that I attended specifically to airway, we were lucky enough to attend the Breathe and Thrive conference this year. And not only were we able to attend, but we were able to speak with, as a lecturer, Tony Ann and I, my SLP director, presented to a variety of medical professionals, from dental to medical to rehabilitative to lactation consultants and speech pathologists and myofunctional therapists and ENTs, oral surgeons. The list goes on. And it was interesting to know, as we were putting together what appeared to be a very elementary level course when it comes to myofunctional therapy and what it looks like and why we determine that a patient needs it. And we were actually more nervous that people would be bored because it did seem so basic, the information we were sharing. But what I continue to learn, and which I learned there again, and it's just one more eye-opening experience, is that the medical, dental, rehabilitative, lactation world knows very little about a tongue thrust when it comes to a perpetuated tongue thrust beyond the age that you should outgrow it, like early toddlerhood. And they are even less knowledgeable about myofunctional therapy and the purpose of myofunctional therapy and when to make the referral for myofunctional therapy. I was so shocked to know that the information that we thought was so juvenile and basic was information that was brand new to them, or even something that they've heard but not really been taught. I definitely would say, and I've said this in the prior podcasts, that myofunctional therapy has definitely taken off in the last few years. And when I mean taken off, I think finally, as there's more and more research coming out of the United States about the benefits and efficacy of myofunctional therapy when treating tongue thrusts and articulations associated with tongue thrust and sleep disordered breathing, or I should say airway issues, or TMJ or issues. As we're seeing more and more success, or as more and more success is being seen and documented, myofunctional therapy has definitely been gaining momentum in terms of skill set and knowledge. But what's so unfortunate is that the dental schools and the dental programs, for many of them, even the dental hygiene programs, they still haven't updated their curriculum yet in order to expand their knowledge on what myofunctional therapy is, what to look for, when to refer. A lot of the dental programs, even the speech pathology programs around the country, have not caught up yet. So it's not only new information for those seasoned professionals that we currently rely on, but it's still not being discussed or recommended on a regular basis, especially when you're going through the educational process now. I know that there's been a big push to make sure or to add coursework about myofunctional therapy, tongue thrust, and the symptoms associated, and the dental, medical, rehabilitative professionals' role when it comes to tongue thrust and myofunctional therapy. But it is still something that the dental schools are still antiquated in the sense that they have not started to expand their curriculum to include something that's really making some headway right now and showing a lot of success. And again, I'm not saying every medical and dental school, I'm not saying every speech pathology program, but I'm just saying on average. And especially as I go out and I'm lecturing to larger groups of dentists or orthodontists, or to dental hygienists and speech pathologists. The more diverse the room, there wasn't an increase in the amount of knowledge that the audience had. If anything, it was a collaborative lack of understanding. Some of the things that ironically, medical professionals and dental professionals often don't consider is that tongue thrust swallow was developmentally appropriate up to a certain age, and if the child or infant was utilizing it the correct way and able to acquire nutrition, then there was no reason to question it because it fell within the guidelines of developmentally appropriate. However, once it gets to that, we're pushing the line where they should have outgrown it and we should see signs of their mature or adult swallow pattern. It's at that point that we're failing to recognize, or if we are, we're making excuses that last too long. And time is of the essence. I don't know why we would be encouraging early intervention across the board when it comes to the development of language and play and feeding skills, etc. Then why are we not taking the same approach when it comes to tongue thrust? If we are thinking that a patient should be able to dissociate their tongue at around 6 months, they should be able to utilize a proper chewing pattern during their early toddlerhood years, then why are we making excuses for our patients that are still unable to do that at 6 or 7 or 12 or 17? And why are we not so proactive with tongue thrusters as we are with, say, a language delay or a feeding delay, or fine motor or gross motor delay? And you would think because of the negative ramifications that a prolonged tongue thrust can have, especially when you're speaking about the oral cavity, the hard palate, the overall facial structures, the development of the muscles and in your face, the negative effects it can have on your joints if being utilized as a compensatory strategy, how a tongue thrust can affect posture and teeth and overall speech patterns, feeding patterns, jaw stability and jaw pain, and then last but not least, but just even those individuals that need more space in their airway and may suffer from symptoms of sleep disordered breathing. It's crazy to me that all of those negative effects, we're talking about feeding and swallowing and breathing, which are some of the body's largest functions to live, why we wouldn't want those systems working properly, and why we wouldn't want those systems being any needs with those symptoms being addressed immediately. Now, ultimately, of course, Is there any harm of death or significant illness or significant trauma if you don't address a tongue thrust? It really depends on what you consider significant. If the child has sleep apnea because their airway is blocked by either their tonsils or adenoids, and then their tongue is falling back and crowding that space more and interfering with their sleep patterns, which is interfering with the development of the gray matter in their brain. Yes, in that situation, I would think that would be not only medically relevant, but extremely important in a developing brain. The same thing when it comes to feeding. If a child is unable to utilize a rotary chew or a diagonal chew even, and recognize how much bolus they should have in their mouth and how they should swallow that bolus, and how that tongue thrust has affected their dietary repertoire and has limited it to some very unhealthy foods that maybe help you gain weight but are definitely not nutritious, then I would think again that now we just talked about breathing and eating and failure to thrive as two areas that can be affected when we're talking about a patient that's had a prolonged tongue thrust. It's just perplexing to me that not only does this area of medicine, rehab, development not get enough attention, but it not only needs the attention, it also needs that intervention. And early intervention, as we all know, is always better, is always going to yield the most significant results, especially as that brain is developing and more moldable. But also, the sooner we interfere or intervene with a tongue thrust swallow that is considered immature or delayed with regards to its development, then the more delayed we're going to see other areas become, like their articulation, like their dietary repertoire. All of those things can be adversely affected. And at this point, we need to make identifying a prolonged tongue thrust a priority, and intervening sooner than later, so that hopefully we can break these negative or incorrect subconscious behaviors, and work on re-educating the neuromuscular system and helping them to establish their adult swallow pattern sooner than later, with the least amount of negative effects or detriments as a result. So again, I caution you to be aware of doctors or professionals that you speak to, especially when you're speaking about myofunctional therapy, because they may not know as much as you think they know. But it doesn't mean you can't take that opportunity to explain it to them a little bit, give them some handouts, give them some research, give them some resources, because in my opinion, especially lately, the medical and dental worlds and rehabilitative worlds are definitely more open-minded about myofunctional therapy, and interested to learn, which wasn't always the case. I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute, and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech-language pathology and myofunctional therapy.